All right, I'm going to start us out with a little preliminaries because it's the first time that we've obviously done this on Zoom. We're going to have individuals here who may want to provide public comment. Individuals who want to provide public comment are asked to raise their hands through Zoom. Anyone who is providing public comment will have 3 minutes. If you get to your 3 minutes or go over your 3 minutes, you'll be reminded of that, and we'd ask that you finish up your comment as soon as is reasonably possible. Board of Health members should be able to raise their hands by using that feature through Zoom, but if for some reason that proves difficult, you can just raise your hand and we'll get you unmuted if you're muted. Little different today in that votes need to be done via roll call. Russ will call out each board member's name when a vote is needed, and you can say aye or no. And presentators will be able to share their screens with everyone. The chat feature is disabled on these public Zoom meeting formats as per county policy. And you know, if at any point anyone needs to take a break, just let us know, and we can take a break. So, anybody have any questions? Jimena, did I cover it all? Jimena, I think you're muted.
Like I haven't done enough of these Zoom meetings to remember to unmute myself. Yeah, thank you, Jim, and good morning, everyone. It's good to see everyone.
It is good to see everyone. I hope you're all holding up well. You look good. So we'll start. We'll call this meeting to order, and we will start at 9 o'clock with public comment. So if anyone has any public comment, they can offer it now or at the end of the meeting. I believe we have a public comment period, do we? Yep. Now is your time for public comment. So please raise your hand, and we'd love to hear you.
Hi, this is Kayla Steinberg. I'll be unmuting you when it's your turn to make a public comment. It looks like we have a couple people with their hands up already, so I'll call on you, and you'll get a notification that you're unmuted. And if you'd like to make a public comment, just raise your hand. If you're in Zoom or if you're on the phone, you can press *9. So I'll start. Marta Larson, I believe you should be unmuted now.
Thank you very much. My name is Marta Larson. I'm a resident of Northfield Township. I know several of you, I think. I'm a member of the Community Voices team for health equity, but it should be noted that I am not speaking on their behalf. I'm speaking solely from my perspective as a resident of the county. First, I would like to ask in the future if you would make your meeting materials available in advance of the meeting. It's very hard to make public comment on something that I have no idea what you're going to be talking about. So hopefully my comments are not too repetitive from what you're already going to be thinking about, but I would encourage you to be more encouraging to the public by making your materials available in advance. When I started thinking about racism as a public health crisis, I thought about a quote from Common Ground Health that says, "Words are hollow unless followed by action." And so with that spirit in mind, I would like to encourage you to address the 3 ways that race influences health outcomes. Those include relational factors, in other words, differences in provider decisions and care driven by conscious and unconscious bias. Also systemic factors, how the healthcare system is poorly adapted to the needs of people of color. And structural racism, how public policies, institutional practices, cultural representations, and other norms work to perpetuate racial group inequity with or without intentional bias. With those things in mind, I would encourage you in the policy effort to make sure that people of color are driving your efforts as opposed to being brought along. That racial equity be put at the core of all department procedures, and that recognize that racism drove and continues to drive the health inequities we see today. I would encourage you to advocate for and adopt policies that improve health in communities of color and address the social determinants of health, including housing, employment, education, community, neighborhood, food, in addition to medical care. In the personnel area, I would like to encourage you to compare the demographics of your current staffing to decide whether or not that it reflects the communities that are being served, and then make goals to remediate those inequities. Analyze your applicant pools for race and gender representation and expand the search where needed before selecting candidates to interview. Determine whether your department climate is in any way discouraging applicants of color or retention of staff of color. And train employees on how racism impacts residents. Finally, in the area of budgeting, I would like to encourage you to analyze your funding by community, especially regarding communities that are racially identifiable, and adequately fund grassroots organizations that are working to address inequities. Those are my comments, and thank you very much for listening to my point of view.
Thank you very much, Marta. And I think you make an excellent point there that we should make our materials available in advance to everyone.
All right, Alex Thomas, you should be unmuted.
Hi, everyone. My name is Alex Thomas. I'm also a member of the Community Voices and Health Equity team. As the previous commenter, I'm speaking as a resident. I'm a resident of the largest neighborhood in Ypsilanti Township, West Willow. And my first message, I want to thank you all. Thank you all for the opportunity to speak today. And for our whole entire community, the last 4 months have been challenging, to say the least, different. It's an evolution. All of us have had a unique experience. I can only imagine what it's been like inside of the health department. So appreciating how hard all of you work, the staff, this board, just what you've been through personally and professionally, I sincerely thank you. I'm a person that's inherently suspicious of large institutions, and I've just been pleasantly surprised in my 3 years experience with the health department. And so thankful for the information that I've gotten. And it's just so poignant at this time. I've been just so fortunate to learn about the social determinants of health that COVID has really exposed how important they are and crucial in any kind of public education policy. Policy. Those social determinants of health, in my relationship with the health department, I know how important it is to you, how the community understands these issues or understands what's going on inside of the health department. So I would ask that you include that social determinants of health, educate the public. It's so crucial at this time, globally, nationally, in COVID, law enforcement. I mean, those are right there, and the public needs to know the information that I've been so fortunate to get. Also in your messaging, I was embarrassed. I've just learned about the 48197 zip code as a person with a 44-year relationship with Ypsilanti Township. Whenever I heard 48197, I always thought City of Ypsilanti. But thanks to my close relationship with the health department, I understand that it's half of Ypsilanti Township in the more affluent part. So when we see those numbers by zip code, I think my brothers and sisters in the city of Ypsilanti, it's kind of a disservice, because those numbers from the affluent part of Ypsilanti Township, it's conflating it. The issue is actually worse in Ypsi City than that 4819 zip code shows. Also, as in Ypsilanti Township, 48198, that includes a large part of the affluent part of Sumter Township. So that kind of conflates our numbers. We need census tract data available so we can really understand with specificity where COVID is most affecting us. Lastly, on the law enforcement issue, it's evolving right now nationally. We have an opportunity here. It's Washtenaw County. There is a community sentiment, and there's an expectation that our public policy reflect what's going on. And I think as a social determinant of health, that everyone knows how important law enforcement and how that impacts so many of the most vulnerable communities. I would ask that you all, put that in your thoughts, put what we know into action, advocate. The health department, it has its highest relevance in a time like this. I mean, you're always relevant. We're talking about life and death. So there's an opportunity right now to rise to the occasion and join the community and recognizing that we have to look at things differently, do things differently. So thank you for all your work. Thank you for this opportunity. Hey, it's Washtenaw County. You guys are the good guys. Let's do something. Thank you. Bye-bye.
Thank you very much.
All right, that was the last hand I saw raised. If anyone else would like to have a public comment, please raise your hand now. All right, I'm not seeing any other hands raised at this moment.
All right, seeing none, I'm going to move along, close the public comment period at 9:13 a.m. And we're going to move to the agenda. Would anyone like to move to approve the agenda?
So moved, Neil.
And do I have a support?
Second, Justin.
All right. Kayla, I guess we have to call off by board member approval of the agenda.
Yep,
Russ,
I'll be
go
doing
ahead.
that.
Oh, Russ, thank you.
So Felicia Brayback,
Yes.
James Cardy,
Yes.
Gina Dolan,
Yes.
Richard Fleece,
Yes.
Leon Golson,
Yes.
and Neil Hajra,
Yes.
Justin Hodge,
Yes.
and Kathleen Stroud. Let me go in and unmute.
Yes.
All right. Elizabeth Vanderpool
Yes.
and Morgan Williams.
Yes.
All right. That's all.
All right, so the agenda is approved. We'll move on to approval of the February 28th, 2020 meeting minutes. Before we move on that, does anyone have any correction to the minutes? Hearing none, do we have a motion to approve the minutes?
I move.
Support?
I second.
All right, we'll have a vote. Russ?
All right. So, yep, Felicia Brayback,
Yes.
James Cardy,
Yes.
Gina Dolan,
Yes.
Richard Fleece,
Yes.
and Leon Golson,
Yes.
Neil Hajra,
Yes.
Justin Hodge,
Yes.
Kathleen Stroud.
Yes. Yes.
All right. Elizabeth Vanderpool
Yes.
and Morgan Williams.
Yes.
All right.
All right, so the minutes are approved. We are supposed to have the executive committee report from February 19th, 2020. That's been a long time ago. I really have no memory of not only that executive committee meeting, but actually whether I was a part of that executive committee meeting.
I believe the minutes were shared,
Yes, but
just for information.
But usually at this point, I share a little something from what we talked about. And as I said, I cannot remember if I was even there. I think unless We have had, as an executive committee, good communication with Jimena throughout this crisis. We have not met as a board because the health department has had much higher priorities during this period. But it's a good moment to thank Jimena for everything that she's done. It's a good moment to thank the staff for everything that you've done. Obviously, we're all, as part of our board membership, I think, more in tune to public health around the state and nationally. And as I've watched what you've all done, I've really been in awe of the work and hours you've all put in. And I've felt very proud to be a small part of the health department and to be a resident of this county. So it's a good moment to say thank you for everything that you've all done.
We appreciate that, and thank you, and thanks for recognizing the staff, because they certainly have been working nonstop during this whole period. So thank you for that.
I'm sure it's one of those times where I think years from now, you'll all tell stories about everything we did during this period, and I hope to hear some of them. All right, so we're going to move on. Next item is our COVID-19 response and strategy. And Laura is going to start off with epidemiology and surveillance.
And before Laura starts, as she gets her slides ready, I just wanted to say it's hard to really summarize all of the work that's gone on these past few months in about half an hour. So we know that this will just really touch the surface of the information and kind of the current situation and the work that the health department has done and will continue to do as part of the COVID response. So as board members, if there are specific areas or particular areas that you would like to kind of delve into further, please know that we can always put that on future agenda item, future meeting agendas. And hopefully we'll still have a little bit of time today for questions that you might have. But just know that this does not have to be the one and only time that we talk about our response and what we see moving forward. So just wanted to share that. And we thought that having Laura kind of give you perspective from epidemiology would be helpful. Dr. Marquez is here to talk about what our plans are as far as testing strategy and contact tracing, case investigation. And then Ruth and Charles will provide an update on our equity response as well. So with that, I'll let Laura take it away.
Okay, thanks, Jimena. Let's see if I can share my screen here and get things going. Okay, so yeah, it has been quite an incredible time. As we say, we've been training for this our entire careers, and here we are. And so again, as Jimena said, it's very difficult to capture what we've been, everything we've been doing for these past 3 months. But I just wanted to at least give a general overview of what I've been doing 24/7 for many weeks here. So oops, that's good. There we go. So let's just go back and do a little bit of a recap of where we've been. And I have to say, March seems so long ago. And in COVID time, this is just ages ago. We talk about COVID time frequently because it just, things change so rapidly that, sometimes last week, whatever kind of rules we were operating on and what was going on is a completely lifetime away. So our first cases in Washtenaw County, we detected on March 12th. So that was when we really kicked into high gear. I think a number of you know that several of us, Dr. Marquez, myself, the nursing team, we were working on COVID starting in January because we had students at the University of Michigan coming back from China. So yeah, I mean, we had been, actively working on this for a number of months before we actually had our first confirmed cases. And so early on, these cases were mostly connected with international travel. largely from Europe, actually. Our early cases were not connected to China. They were connected to Europe as our college students came back from spring break, and people, and also there was, I'm sure a number of you heard about the spread of disease that happened in the ski resorts, both in Europe and in the United States, that was a huge kind of incubator and spreader across the world, were the ski resorts in February and early March. And so kind of early on, we were very focused on where have you been? Where have you traveled, as folks were, as we were starting to detect those first cases. But then, as you can see, 1 week in, we'd already found our first case that person had no travel. So, were they, and I don't think we were able to directly connect them to a traveler. So people ask me frequently, well, did we have COVID circulating before we picked up that first case? Yes, we probably did, but I don't think it was really widespread yet. I think there were probably a few cases out there that we missed for sure, but I think it really ramped up starting in mid-March. And as again, we had, I think, multiple introductions of the virus into our community. So our first hospitalization happened by March 15th, and unfortunately our first death by March 22nd. So again, things moved quickly. And just to think back, and Dr. Marquez is going to talk a lot more about testing, but back in March, just to remind you, at that point, the only place to get a test, originally it was at the CDC. We had to ship specimens to Atlanta to get them tested. And we were on it. I think, we were in the United States, Washtenaw County was 75th. We were the 75th test in the entire United States. I mean, we were sending tests down there. I mean, we had cases, folks that met the definition to get tested at that point, but it was super difficult to get tested. And then our state health department got the test, which was good. That was an improvement over having to send specimens to Atlanta. But the way that worked was the local health department, us, and of course, all of our other colleagues, we were the gatekeepers of the test. So every single physician in Washtenaw County had to call us and ask us, hey, can I test this person? And we would say, yes, if you've already tested them for flu and they don't have flu and they don't have other things that we are expecting this time of year. And so that took an enormous amount of staff time in those first number of weeks as we were just triaging who got to get tested or not. And again, that we know we missed folks back then because again, it was super strict and it was such a restricted commodity. I mean, there were so few tests available that you really had to be super sick to get tested early on. So did we miss cases in March? Absolutely, because of how restrictive that testing was. So let's just look at, and I'm calling this our first COVID peak because I think we're likely to see another one, but we in Michigan, we've had a very clear rise in cases. This is our peak in Washtenaw County. You can see, and this is by week, and this is by onset date. So this is when people actually started showing symptoms, and you can see how rapidly things rose in March, and then we peaked in late March and into early April. And then slowly came down, and as you can see, as things kind of over here where we are now, it's what I call we are currently simmering. We have circulation of the virus is continuing at a low level, and unfortunately at any point that could start rising again. But again, we have a very clear, you can see the effect of the stay-at-home order and that the decrease in people, the interacting with each other and how effective that was. So what were we doing during that peak time? Just again, to give perspective, our nursing staff and our case investigators, which also included some of our sanitarians, we were getting 30 to 40 new cases per day. In 1 week, we had 88 hospitalizations due to COVID. That was definitely our peak week. That was right at the beginning of April. But what's interesting is the deaths. Sometimes, unfortunately, people die from this disease fairly quickly within several days to a week. But unfortunately, many times it takes a while for this disease to take its toll, or we've had people for a number of weeks on the ventilators. And so the deaths tend to lag by about a month in terms of where the peak is. So our peak of deaths so far, unfortunately, was the first week in May, and when we had 21 residents die that week. And so during this first big wave of COVID that we've just come through, who got sick? You know, what happened in terms of, you know, who were we following up with? Certainly our healthcare workers. We had a lot of healthcare workers get sick. Other essential workers, as we know, our grocery store clerks, other folks that had to get out and work. That absolutely, we saw that over and over in our first wave. And unfortunately, we learned fairly early on that our African-American residents were more vulnerable. And we are currently sitting at 40% of our hospitalizations are in our African-American residents, and they only represent 12% of our population. So that's way more hospitalizations than we should be seeing. And so certainly they have been more vulnerable to this virus. And then the other group that really has shown up, that of course has gotten a lot of press and is absolutely true in our community too, are these residents of congregate living settings. And so these are not only our nursing homes, and so those are the ones that are listed on the state website. We have 10 kind of active nursing homes that are licensed, but we have many, many more assisted living, other kinds of places where we have had outbreaks. And so group homes are correctional facilities, the Washtenaw County Jail, and I'll say a little bit more, maybe on my next slide, I don't remember, but so we did not follow up. Again, we have many correctional facilities in Washtenaw County, including the women's prison that I know that this board has been quite interested in, but the women's prison they have been covered by the Michigan Department of Corrections and the state folks. But I can tell you, they've had a huge outbreak at the women's prison, as has the Milan Federal Prison. And that also, again, is not, doesn't, in a way count in our jurisdiction, but we had, Dr. Marquez and I had a number of phone calls with the staff down at Milan as they were trying to sort out what was happening within their prison setting. But in all of our certainly correctional facility settings, we had staff that worked there that also became positive. So again, we interacted and responded to those cases as well. And so again, a little bit more about these outbreaks in these congregate living settings. There were over 20 different clusters and outbreaks that we managed, and that we were working directly with these facilities. And the way that we did that, particularly for any of our assisted living or nursing facilities, is that we assigned one of our expert nurses to be the kind of liaison to that facility, so that they could really get to know what was the setting there. Did that facility need PPE? What was that facility willing to take COVID patients, or were they transferring them all out? Some of our facility outbreaks were very complicated. And so, yeah, that certainly is an ongoing issue that, the state is recognizing and really trying to figure out how to do this better, because again, we had a lot of folks get sick in our congregate settings. And yes, I already kind of spoke to that. Any of the state or federal correctional facilities, we didn't directly handle, but we did a lot of consultation with the different settings. And so this is what I hope you're all familiar with our data website on our webpage. So our EPI team has been working very hard. At first, we updated this every day, including weekends. And then as things calmed down a bit, we decided that Monday through Friday was okay, since we also knew that the state was updating their data over the weekends. So, and, I think this reflects, currently you can see, I pulled this a couple days ago now, that we're over 1,400 confirmed cases. And we're also reporting our probable cases, and we were one of the first in the state to do so. And again, the probable cases still don't reflect the true level of infection in our community, because to become a probable case, you still need to, let's say, have been a household member of somebody, live with somebody who had COVID-19 and you got sick, but then for some reason you couldn't get tested. Maybe it was early on in March or April when testing was so much more restrictive. And then maybe now you're getting a serology test and your serology test positive. And so our nurses call up and find out like, oh, hey, yeah, I was sick back for 3 weeks in March. I lost my sense of taste and smell, and my roommate had COVID. So then we say, yep, we're pretty sure you had COVID as well. We're going to call you a probable case. But the only cases that end up in that lab confirmed case line is if you had a nasal swab and they found the virus in your nose, or, your nasopharynx. So that's what we've been reporting out. And then I didn't make a screenshot of the rest of our site, but we've been reporting out by race and ethnicity and age and gender, and really and by geography, really trying to kind of cover all the different areas and look at how this this pandemic has affected different parts of our community in different ways. I'm trying to think if there's anything else I want to say about our data. Again, I think it's telling that you can see 27% of our cases have been hospitalized, and that's pretty high. And I think that also reflects early on that you had to be pretty sick to get a test. Now our hospitalization rate is much lower as we're testing more mildly symptomatic people and even asymptomatic people. And again, I think that, but again, early on in this pandemic, that's, that rate was of people who got tested and were positive, a lot were ending up in the hospital. And as you can see, 8% of people ended up in the ICU as well. And then I just wanted to make people aware of this, I think a very helpful website that the state has worked with the University of Michigan to create, this Michigan Safe Start map. And I pulled this data or this screenshot a couple days ago. And at this point, even though the Detroit area, which is what we are in, looks lighter yellow, we're all the same color in the whole lower part of Michigan. And that's the medium risk rate at this point. And what that means is, so currently our positivity rate in Washtenaw County, we're testing at about 1.3%. So, which is actually low. That's we really hope we can keep our positivity rate there. We are testing 500 cases per day. And just to let you know what that means, sometimes that means right now we're running between, I would say, 5 to 7 cases, confirmed cases per day. So that means, we have 490 negative cases. And some days all of those negative cases come over the fax machine. So sometimes we're triaging, 500 lab reports, trying to find those 5 positive ones and trying to sort through everything that's going on and making sure that we're reaching the folks with a positive lab as quickly as possible and knowing, kind of where, again, who's testing positive, who's testing negative, what's happening across our community. And that, I think, is my last slide. And it sounds like we're not taking questions at this point, but I think most of you know how to find me if you have a question. So thank you so much. And I will turn this over to Dr. Marquez.
Thank you very much, Laura. While Dr. Marquez gets ready, I will share with you that as part of my job, I have data on a daily basis out of FCI Milan. And the current cumulative statistics are 92 inmates have tested positive. 3 inmates have unfortunately died. All of those 92 have recovered except for 13 that are currently being treated. 55 staff have also tested positive, all of whom have returned to one.
And I would also just share that the Washtenaw County Jail actually has kind of created its own dashboard where they've been sharing also information about cases that they've had in their facility. So that's actually available also on the Washtenaw County Sheriff's site. And, you know, depending on how much time we have left, hopefully there will be time for some questions at the end, Jim. Certainly feel free to facilitate questions at the end of this presentation.
All right, can everybody hear me okay? And see the screen okay? All right, perfect. So, so I'm going to talk a little bit about testing, the case investigation process and the contact tracing process, kind of focusing more on what sort of we've been doing rather than present the data like Laura did. And again, if there's any questions at the end, feel free to just jot them down and let me know. So the first thing is, mark here. So I want to talk a little bit about the types of testing, what's been previously done, what's currently done, and then the future state. So I think there's a lot of confusion when we talk about testing, right? So what do COVID tests actually mean? So at this point, there's essentially 3 types of tests. So one is a PCR test. We'll talk about what that is. The other one's a serology or antibody test. And then there's something that's typically not done. It's basically to be an antigen test. And we'll kind of touch on that very briefly. So the PCR test is the most common test that you're going to see. That's when, if you look at everybody who's basically garbed up in a white gown and just like a face shield, it's basically what they're doing. So the PCR is basically picks up viral DNA. Now, the important part here is it can pick up alive or dead DNA. It doesn't distinguish between that. And that's important because I'll talk about that shortly. But so it can be nasopharyngeal. So that means it's a long swab that goes all the way back and kind of tickles the back of your throat. An oropharyngeal, which is kind of goes kind of in the middle of your sort of down your throat, tickles the middle of your throat, and then nasal, which is just like right here, nasal, probably mid-terminate. So the pros are that it's very sensitive, very specific, and at this point, it's fairly widely available as compared especially to the antigen test. The cons are it's time intensive. So the actual test is very quickly. So it's actually 4 hours, but by the time you get it to the lab, you get it back from the lab, it can be for anywhere 2 to 4 days, especially if they're running at peak capacity. And then the rapid test is done in 15 minutes. So these are these kind of Abbott Now tests. I think Sophia also has a test. They're done in 15 minutes, but there's concerns about sensitivity, and those I think have been published. So, you know, one thing about that is that our BOL took a sample of negative tests from Detroit, who has been doing a lot of rapid testing and has found pretty good correlation between what they're finding and sort of what the lab has found. So, sorry, I think actually they did, yep. So they actually compared with PCR, sort of like normal PCR and a rapid test, and they found pretty good correlation. So the big problem that we're seeing now is that we really can't differentiate between infectious and non-infectious. So what I mean by that is that if you go and get a PCR test done, they stick a swab in your nose, you roll around, pull it out, test it, it comes back positive. You might not have any symptoms, especially now where it's becoming more widely available. But the problem is we don't know if you're infectious now or if you're infectious months ago. So it basically can't distinguish between infectious and non-infectious. And so we've seen shedding go on for months and months. So it could have been that mild cold somebody had, you know, weeks or months ago. is actually maybe they had COVID, as Laura said. We weren't testing widely enough then, but now we're just picking it up. And so it's a little bit tricky to sort of figure out whether or not a asymptomatic person with no symptoms is really infectious, but we do treat them as such. And this really comes to play really in congregate settings where we don't really want folks coming back from an isolation area to the general population until we really feel comfortable that they're not infectious. So then the antigen test it basically detects little molecular markers. Like if you look at the ball and spike, it picks up like those spikes. It's not widely available. There's an emergency use authorization on 5.8. So I haven't heard of anybody getting these tests, but it's available. It's potentially very fast, easy to use. The cons are it's got low sensitivity potentially, but again, this has not been widely available. So then the serology tests are basically they can detect IgM, IgG. So these are the antibody tests that I think we've heard quite a bit about. So these can be either through a lab, for example, Michigan Medicine, Quest, one of these big ones, or a point of care test. You basically go, they do a finger prick and then do sort of point of care test. Now, the issue is that it's not currently approved for diagnostic purposes. So it can be done for either research or public health surveillance, but it cannot be done to tell somebody is currently actively infectious. The tricky part here is that there are a lot of unknowns about serology tests at this point. So the good part is that it detects exposure. So we don't know how long that might be. And then it's in the future, not now, in the future, it's got the potential for detecting immunity, but there's a lot of caveats that are associated with that. Some of the cons are that, again, it's not universally reliable. So initially with PCRs, the FDA really, and the CDC, really had a very, very, very limited number of PCRs they were made available. So as Laura said, it started the CDC, then it went to state health departments, and then to commercial labs. Now, they realized that that was a mistake. And so with the antibodies, they went the other route. Well, they basically just let essentially anybody get emergency use authorization just by letting them know, giving them their data. What they realized was that that's sort of on the other spectrum, and that caused a lot of trouble. Many of them were unreliable. And so, one of the issues with serology tests is that there's so many, and they're kind of scaling back now because of this issue. But especially initially, we didn't know how the performance was. And so even those that have good tests, even those that are doing through Quest or Michigan Medicine, we don't know if it indicates immunity. We know it indicates exposure, but we don't know that it indicates immunity. And then once, even if we do know that indicates immunity, we don't have the studies to figure out how long it's going to last. It could be weeks, it could be months, it could be days, right? Probably not days, but it could be weeks, months, years. And so there's a lot of caveats with serology, but there, again, so the pros are there's a lot of potential for future use for serology tests. So as Laura touched about a little bit. So in January, February, really the CDC was the only lab with testing available. We'd have to get approval through the state and then through the CDC. Collect everything, ship it to our state lab, ship it to the CDC. And so the turnaround time there was quite long, was 7 to 10 days. And then in late February, MDHHS and other state labs were made available so that we could send them up to MDHHS. There's very strict criteria at that point. So you had to have basically a very strong travel history to specific parts of China. And then you could, with very specific symptoms. So for example, if you had traveled next to Wuhan province, but not to Wuhan, and you had all the classic symptoms we would consider now, you weren't, it wasn't available for you, you weren't a candidate for testing. So MDHHS started opening up labs mid-March. We had more commercial labs opening up. Early April, we had some drive-through testing start opening up through St. Joe's and then Michigan Medicine. And then in early May, and then continued now, there's been increasing testing through community partners. The note I put here is that strict criteria and reagent capacity issues have really limited availability of testing. So initially, again, there was only a certain number of labs that were doing testing. Once that got opened up, the criteria got opened up. But then at that point, there were reagent issues so that there weren't enough reagents to do all the testing. Once that got resolved, there also wasn't enough sort of swabs to do the testing. Once that got resolved, then we had capacity issues. So sort of time over time, we've had issues that have stopped us from doing the amount of testing that we think would be sort of feasible and would be beneficial. So current state, so we do have a number of increased testing sites. So If you go to washtenaw.org/COVID-19, there's a tab that, Kayla's done a great job putting the entire site together. There's a tab of testing sites. And so there we have a number of pharmacies, CVS and Rite Aid, that will do testing. We'll have the drive-through through St. Joe's. Michigan Medicine also, again, has their site, but they require essentially an order to go through them. And then there's a number of urgent cares that are doing testing as well. And these, most of these, I refer to the PCR testing, but urgent cares will also do serology testing, as will St. Joe's and Michigan Medicine. There's been multiple state initiatives to increase testing. I'll be honest, some of them have been better than others. So the National Guard over the last month, I guess, has gone through and tested at congregate settings, specifically skilled nursing facilities. It's a good thought, but I think they've had a lot of problems with getting the results back in a timely fashion. There have been moonshot initiatives that have been put on by the state that, again, were talked about, but I don't think were realized. And now they're doing these pilot tests where they want to basically have testing initiatives where they go in, they ask for local health input, and then turn around in about 2 weeks. So we're working on one of those initiatives currently, and we'll see how it goes. So locally, we've done some outbreak surveillance. So meaning that we have, so the one thing I think that is hard for many times when we get questions is that, why don't we do more testing? So there's a few reasons for that. One of the reasons is that our staff that does the testing also does the contact tracing. We don't have a big, unlimited staff. So any staff that we take out to do the testing, we pull them away from contact tracing, which we'll talk about a little bit. So it really has to be sort of, I think, a very big value add for us to do the testing. And so we've seen that a few times. So some of the pop-up sites early on in May, I think were valuable to do in IPSI to increase the number of tests in that area. We've also done some in some areas where we've seen increased activity, increased cases. And then we also did a few, for example, if a group home does not have a nursing staff to do the testing, our nurse practitioner, Kathy, has gone out and has done has basically tested everybody there. And so we also, we'll talk about a bit, we had a cluster of in the Latino community. And so we did a pop-up site there very quickly within a week to see if we could capture additional cases that we just weren't picking up. And then there's, a lot of the effort has been at these long-term care facilities, so SNFs, assisted living, and so other sort of group homes because of the increased morbidity and mortality that you see at these facilities. And right now, the state's taking basically the lead to do the testing there. So, I think in terms of future state, I think we, I didn't put the recommendations, but MDHHS recently sent out, the State Health Department sent out recommendations for increased testing frequency recommendations, and they are pretty aggressive. I don't know, honestly, if they were all followed, I don't know that we'd have capacity. So because everybody that goes out to work should be tested every 2 weeks. Everybody that works in a healthcare setting should be tested every 2 weeks. If there's an outbreak in a facility, which we haven't seen lately, but in early April, May, all the staff, all the residents should be tested weekly. And so the recommendation is for very aggressive testing. And there's a number of good reasons for that, but I don't know that we would have just the capacity as a whole. And so I think that the state is trying to increase that capacity through, again, some of these moonshot efforts, and then also partnering with some commercial labs and some pharmacies as well, CVS, Rite Aids. So from our end, again, I mentioned that we don't have the staff to do the amount of testing we want to do. But there are now coming many more commercial labs. And so we're working with a couple local labs that we're hoping to have partnerships with to do some of this testing. So one example of that is testing over in the Whitmore Lake area. So there's a lab that has contracted with, it's a very interesting model, they've contracted with nurses, and they will actually go out and do the testing and then work with us to get the results. There's another local lab that potentially can help test dentist patients, because if you look at like Michigan Medicine, St. Joe's, the recommendation is for pre-procedural testing, but like dentists who are pretty high risk, like you have open mouth for a period of time reading into dentists, they don't have that opportunity yet. So we're working with a lab to figure out if we can help with that. And then again, there's a lot of these serology studies that we need more and more data to figure out what they mean, but there's a few efforts from the CDC and first responders in our area. And then Laura also already mentioned this, but so if you see here, the positivity rate was basically because of the criteria that was required. And then over time, as the criteria has been loosened, you see the rates going down, and then the increase in testing over time. And then Laura already mentioned the positivity and low positivity and the number of data tests administered. So I'm going to just talk about briefly about our investigation and contact tracing. I think that there's been a lot of information about, how important this is. I agree 100%. And so I just wanted to give an overview of what it entails, because it's not anything sort of magical. Who's writing on this? That's not me. So I hope it's not somebody just writing on this one. All right. So the case investigation and contact tracing. So basically it starts with a lab or a clinical report, right? So basically we get a positive lab, and then we contact the patient. And so we, typically by a phone, maybe they'll text. Many people don't like picking up phones. We'll get information from them, demographic, clinical, epidemiologic information, and context. So of these, the demographic information is super important. Clinical is very important, but I think the biggest one here is this context and epidemiological information. Where were they and who were they around, right? Our team, our nursing team does not, they manage the symptoms, but we really refer folks to, if they have symptoms, to go to see the PCP or their EMS. Really, our goal is to really find out contacts and isolate them or quarantine them as quickly as we can. And so that's a lot of the time that's spent, a lot of, I think, the value that's coming from case investigations. We provide isolation information. So what does it mean to actually isolate? And then we provide education about what they, again, what the disease is and what isolation means and what they can expect. So we provide resources if needed. So Ruth has done a great job of, Ruth and her team has done a great job of providing housing for anybody who needs it. Kim and Kim Collum and her team has done a great job of providing all the resources, food, groceries, and then barrier buster referrals for those who are having trouble paying the bills but have to be quarantined. We follow up every 3 or 5 days, and then at the end we say, thank you, everything looks great, you have been symptom free, we'll discontinue your isolation at this point. So then the second part of that is, you might have one person, but then they might have multiple contacts. So for each contact, we ask for the name, city, a phone number. And so we then communicate with our contact tracing team, who will actually call each person or text them and give them the appropriate information about what it means to be quarantined, get a bit more information about their symptoms. And so again, for them, we ask for them to be quarantined, so we provide resources as needed. If they can't quarantine safely at home, we can provide some quarantine resources over at the Red Roof Inn. They do regular check-ins to make sure they're not symptomatic. If they become symptomatic, they go from being just a close contact to a case. And then we, again, hopefully at that point, they haven't been near anybody else. So it should be a very limited exposure. But if not, then we do the whole process over again. And then we do things such as contact the workplaces to provide education about what it means to have, if they did have somebody who was a case, what sort of cleaning protocols they have to do, who they have to notify, and what they have to think about. And then we contact places where they've been, restaurants, et cetera, to make sure that they're aware that there's been somebody there and potentially have their staff tested. So just in terms of the staffing that we've had, so prior to reopening, so really at the peak, we had 9 of our CD nurses. We had 4 part-time on-call nurse practitioners. We had 2 of our nurses from the Children's Special Health Services, 3 nurses from MIHP program, and 2 sanitarians. So as we reopen, we have to reshift, services that we give to be able to, provide all the services. And so currently we have 7 nurses, and then what we try to do is basically for the short term until we figure out a long-term staffing plan is really use the world-class resources we have here to sort of supplement some of these. So with close supervision, we have 2 medical students that come in monthly. We have 2 epi students at Laura's supervising, and then we have 5 HBHE students that are doing some of the contact tracing. So again, in the short term, what we're doing is filling in some of our nursing team time with some of the trainees, and then closely supervising them. So one of the things, I just kind of an example of one of the things. So Dr. Pierre is a resident who's been working with us from the U of M. And so he's put together basically an onboarding guide for case investigations. We get medical students for about 1 month. And so we have to onboard them very quickly. And so what he's put together is basically every resource, every guide you can do to get them up to speed. We do daily check-ins with them, rounding basically, but he's done a really great job to basically put all the information into one package for them. And we also share this with our some of our staff, some of our team over at the U of M, who's helping us out with on-campus investigations. So Laura showed you the data. So this I pulled it, I think, even before Laura. So 1741 cases, problem confirmed. And then from the contact tracing team, we've had 823 non-household contacts and travelers that they've gotten in touch with. So either phone calls or text messages to them. So this is a high volume of people that we've talked to. And this is just kind of an interesting thing. So we've, the data is not entirely accurate. I think because we just started putting in data into MDHHS, but I think probably about May is when you start seeing this. So this was, you can see that in June 1st, when the stay-at-home orders got lifted, these numbers are starting to creep up. So all the close contacts, and it used to be just household contacts, but now it's starting to be, I went to this party, I went to the store, and I went to see friends. It's starting to creep up, and that's kind of the thing that we worry about: increased exposure and increased potential for spread. So this is kind of an interesting. So I just wanted to make this. I don't know how much time. I think I'm probably running out of time, but I just want to give an example of like what this looks like, right? So this was a birthday party that was in the Latino community in Ipsy, right? So the red dots basically show that people who are affected. The blue dots are basically people who are not affected. So this is basically a party. So this is what a cluster looks like, right? So we had a lot of trouble actually getting in touch with folks to get them to trust us. But from the information we pulled, so this is the connectivity that you see at a party. So everybody's connected with each other, right? All it does is take one person to go from a party to connect to somewhere else and start spreading, right? And so I can guarantee we had a lot of trouble connecting with the particular because of various reasons, but this was one that they were willing to talk to us. Again, all the reds being infected and all the blues being sort of non-infected. I think there are probably 2 or 3 other ones that we just could not pin down. So I just want to give you an example of sort of what the work is that when our contact tracing team and our case investigation teams talk to, and their work that's involved in this. So just kind of the last few slides. So we are measured by the state health department to see how quickly we're getting back. And that's meant to be supportive, not punitive. So to make sure that we have the resources we need to contact folks. So the targets we have are basically, did we attempt to contact one of the case within 1 day of the referral date? So did we call them? Did we text them? Did we make an effort? Second one, did we finish that interview? So it's a very long interview of things that we talked about. Did we finish that within 1 day? And then did we at least contact one of their close contacts within 1 day? And so, and again, speed is the most important part there here because we see incubation periods about 5 days, right? So you can't sort of wait too long to contact all the contacts. And then did we document, because of, again, the disparity we've seen in race ethnicity, did we document race ethnicity so as to have appropriate data and understand the trends? And that's it for me. Sorry if I think I might have gone a little bit long.
Hello, everybody. I think I'm going to share my screen.
Ruth, just before you start, I just want to remind all the panelists and Board of Health members to stay on mute if you're not presenting or talking. Thank you.
I'll start my video. Okay. Okay, so Charles and I are going to talk about the equity response. And it is honestly really hard for me to think back to March. It's almost a blur. I look at some of my old notes. When we were investigating each possible case, spending a lot of time on referrals. And in the middle of March, as you know, we were told basically to only focus on COVID response and essential tasks. So that all, of course, raises the question of what is essential. Juan and Laura talked a little bit about the disparities in our racial and ethnic data. We were actually the first county in Michigan to put this data out. And this highlighted both racial and geographic disparities. Disparities in who was getting COVID, and what the health outcomes were like for them. Since that time, we have continued to mapping, and we've been assessing recent trends of the last 3 weeks. Now, this is especially important when we're looking at geographic disparities, because we've started thinking about how can we track hotspots and how can we use our data to guide our response. So when we published the race and ethnicity data, it was still very hard to get tests. Testing actually became more available in early May, and I know that Juan and Laura both spoke a little bit about this. It's still kind of limited. It's limited in certain areas, and different locations have different rules. Both hospital systems have started ramping up outpatient procedures, and they're doing some testing. So they don't have like untold numbers of tests. So when we were able to develop partnerships, they were like, we have this many tests we can give you. We can do 200 tests, and we only have them for 2 weeks. So we were still very much operating in sort of a time period of constrainment. So we were able to develop some really great partnerships that focused on areas that we had concerns about. And we were able to use the data that we had gotten from our EPI team to sort of direct us. So we did, with St. Joe's, 2 pop-ups in the Ypsi Township Rec Center and in Sugarbrook, both in the east side of the county. And they also did testing at the Shelter Association of Washtenaw County. You may or may not know that in Kent County, one of their shelters, 1/3 of the people tested positive. And because of that, it sort of fueled a huge outbreak. So we were very happy that our shelter association, which we had been working very closely with from the beginning and had instituted pretty strong screening procedures early on, when we did have a few people early on who tested positive from the shelter association. But since then, they really haven't had positives, and there were 0 positives from that. With Michigan Medicine, we were able to do 3 pop-ups, 1 in West Willow, 1 at the Ypsi Township Government Center, and 1 at Bethel AME in Ann Arbor. Overall, the positivity rate at these places has been running 0 to 2%. We also have Packard Health, which is our FQHC, has been doing testing at Perry Elementary School, and we and Kroger Health has been, they did for about a month, 3 weeks or a month, they did testing at Ford Elementary, and on the back end, we were facilitating those partnerships. We also, the health department itself, so Juan showed you the slide with the outbreak in the Latinx community. And so we decided we should try and do a pop-up for that. And so we arranged with one of the churches that this group of people was well connected with. And they actually work out of St. Matthew's in Ypsilanti. So we were able to do on a Sunday a pop-up. And that positivity rate was a little bit higher, closer to 10%. So I think as we look at pop-ups, that's one way to approach them. We are currently talking with, Juan mentioned that we're talking with this private commercial lab, and we're talking with them about doing a pop-up test site in Whitmore Lake. And if that's not possible, St. Joe's may be able to do it for us. So that is on our radar screen. The pop-ups actually turn out to be pretty time intensive. But I think the good news, first of all, I think the communities were very appreciative. But I also feel good that the positivity rates were not, with the exception of the Casa Oracion one, the positivity rates were not really that high. And so they were comparable to everywhere else. So I think that made us feel a little bit relieved. And since that time, testing's only gotten easier. The latest was the Rite Aid on Grove Road. So we've also done a tremendous amount of work around communications and materials, and some of this has just been general. Some of this has been focused on people who have less. So Jennifer Brasso and Kim Collum developed a relationship with a group of people in Dexter who wanted to do a lot of mask sewing, and we've been able to provide masks at every pop-up site and a lot of other places. With the support of the county, we've been able to provide ongoing isolation quarantine housing. And this has taken a huge amount of logistics work on the part of Jennifer Brasso and social work and nursing support. So it's really been a team effort. That is available. Mostly who has taken advantage of it is people who have been homeless, but not everybody has been homeless. We have been doing a lot of video on social media and trying to put that out both in English and Spanish. We had, in Spanish, we actually, we had Juan and one of our health plan outreach workers do a Facebook Live event all in Spanish, and Jimena has done a couple of videos. And then we had the special Facebook Live event in the evening, Club Quarantine, which was really both about music, there was a DJ, and also about sharing information and giving answers about COVID. And we have responded to thousands of questions via phone and email. And many of them are coming from businesses, but a lot of them are coming from people who are low-wage essential workers, who are concerned about where they're working and their situations. So as far as community work goes, we've done a lot of outreach and coordination, both with housing providers and other nonprofits. We've done a lot of work with individuals. We've distributed masks and testing. When we started out, we were told basically that we could only do the most essential work. Over time, that sort of idea of what was essential besides COVID work has expanded slightly. So we were able to bring in our community teams, the Community Voices and Health for All teams in June. And it's very much our intention to integrate them more in the summer, fall, winter response. And I realized, Charles, I was supposed to have you do this slide. Keep talking. Sorry about that.
No problem. You know what? I just assumed, I was like, you know what? Ruth is trying to save time. So I was just going to let you go ahead. But thanks and good morning, everyone. So our community outreach has and continues to be an integral part of our COVID-19 response. And I'll just take a minute or two to talk about some of these efforts. So we've been a part of outreach and coordination with housing providers and other nonprofits. Juan mentioned that a little bit earlier. We've assisted in the staffing of various community food and essential supply distributions. And we've used these events, we actually use these events to promote community testing dates and locations. In addition, as Ruth just mentioned, we helped coordinate outreach with who had mask needs, and we helped with the distribution of that effort as well. We also brought in our community voices and Health for All groups. And these are partnerships that we have with community members and partner organizations to address the health in our hard-hit communities. And we'll continue to integrate them more in the fall, the rest of the summer, in the fall, and the winter. Additionally, we are part of the Communities of Color Task Force, which is a group made up of professionals who are also people of color and represent various institutions, including higher education, secondary education, social service organizations, law enforcement, faith-based organizations, and elected officials. This group was convened by our racial equity officer, Elise Asbury Payne, to provide a direct response to COVID-19 and its impact on communities of color. We also staff various community food and essential supply distributions as well. We created an equity unit within our emergency response team to address equity that helped us use our public health expertise, but more importantly, it includes the voices of people in communities who have a unique COVID-19 lens through their lived experience. So as I finish up my brief comments, our health department, like everyone involved in COVID-19 response efforts, have some lessons that we learned as we move forward. So we were able to convene the health systems and partners to set up testing sites very quickly. We also know that the lesson learned is that as we move forward, this will be very important once a vaccine is created and ready for distribution. Two, as a result of our spring COVID-19 experience, we will be able to mobilize our public health response in communities of color quickly. And then lastly, we're better prepared to determine how the practical application of our public health messaging will affect communities of color. And we will use this experience to help with messaging in the fall, in the winter, and as we move through the rest of the summer. That's all I have, and thanks, and I'll turn it back over to Jim.
Jim, I think you're
You're
muted.
muted.
Now?
There we go.
Excellent. Thank you. I'd like to thank everyone for those presentations. They were extremely informative, although you said at the beginning that you would have to be somewhat superficial. I thought they were extremely informative. I think we have time for questions. Does anyone have any questions?
I think Morgan does.
Morgan. Hi, thank you. I appreciate especially that last slide on the equity and the lessons learned. And so I want what I say next to be not a point of critique, because I was with you all working and doing the work as this was happening. So this is really coming from a passionate place. So excuse me if my comments are inappropriate, but there were some, I want to understand the cadence and how moving forward as we address the pandemic, who will get testings first. So it was interesting to me to hear that we knew early on that the Black population especially were disproportionately affected by COVID, yet we did not prioritize getting testing to that community first. And again, I want to caveat with the fact that I know getting the testing out in general is a positive, and it's something to congratulate us on. But why wasn't that neighborhood, given that we know the stats early on, why weren't those zip codes prioritized first? And more than that, what is going to happen next round when we have another increase? And what are some internal workings going to happen with staff so that people recognize that that's the community that should be prioritized first?
So Morgan, those are great questions, and thank you. And I know that we've been working alongside with you and others at OCED and appreciate the partnership. I think that we did prioritize testing in those zip codes and started working on it pretty immediately. I think the challenge, unfortunately, was what Dr. Marquez and Laura have mentioned in terms of both our capacity to do the testing ourselves in terms of, the staff time to do that, as well as the testing supply. that was still at that time, and we're talking about, like, we started probably in late April to focus on this, was still pretty limited. And so that's when we started having conversations with people at St. Joe's, like Elizabeth and others. We started having conversations with Alfreda Rooks at Michigan Medicine, because we knew that at least for a pop-up testing clinic, you know, we were not going to be able to do that on our own. And so I think we all had a pretty high level of frustration about how long it took to get that in place. And so I think I would certainly hope that now, given that we have more testing ability, where we've started to develop these partnerships now with private labs that are willing to support testing efforts. And we have hopefully also some more funding coming to the health department to support our efforts. I certainly hope that our response would be much faster, and that we would be, as Ruth said, really looking at the data as well, continuing to look at the data to help inform, you know, our strategy and our response. And I think that one of the things I just wanted to add, and thank you all to all the staff who presented. One thing I did want to add is we've also talked about doing an assessment of our response. And so kind of looking back, really getting feedback from the staff that were involved on the front lines of the response, but also getting feedback from our community partners about our response, about, you know, what were the things that worked well, where could we improve, and really taking that information to help us be prepared for, you know, a second wave or new spikes that we might see. So I'll let Juan and Ruth and others chime in if you have other things you want to add, but I really appreciate that question and talking about that, Morgan.
Yeah, first of all, I just want to say to Morgan and Teresa and OCED have really been tremendous partners in all of this. One of my, and I think Jimena is right, that we'll be doing an evaluation. I'm really looking at what we can do. Morgan, I'm hoping that we won't need to do pop-up testing anywhere, because it will be so easy for people to get tests in the same way that, and in the same way that people can get a strep test easily. And I'm also hoping that vaccines won't be constrained. But one of my lessons learned is that when we think about pausing work, that, like, what is essential if you think you're going to be pausing your work for 2 weeks is different from what is essential if you think you'll be pausing your work for several months. So one of my things is I would have liked if we had been able to bring in community voices and health for all teams earlier, but this is one of these hindsight is 2020 thing, and that's why we put in there that we will be including them as we plan for the future.
And I'd like to add to that, and that's that one of the lessons learned from me, both personally and professionally, and I mentioned it in my comments, was the need for us as a health department to try to do the best that we can in anticipating how our public health messaging will impact communities of color. I think that, or even harder hit communities, and really thinking that over as not only as we roll out or push out our messaging, but also, and probably more importantly, and Ruth just mentioned this, in working with our community partners, particularly those with lived experience, to help us with that. That's some of the feedback that we've received from some of the folks who are on our community voices group and also our Health for All groups, that they want to be involved in this response. And moving forward, I think that as a health department, as we talked internally, we realized, as Ruth said, to bring them in as early as possible when we're going to push out messaging that will affect them and the people that they serve.
Thank you all for the feedback. It helps me understand a little bit. I would just encourage moving forward that we do collect data. We know the opportunity in low opportunity areas. We knew 48198, 497 was one. We also did know the homeless population was one, but because we were proactive in doing that work, we also knew that there was really great strategies in screening in order to really prevent folks from getting the virus in those congregate settings. So it is disappointing to know that the fact that we did actually know ahead of time that the lowest opportunity areas will be most impacted by a health pandemic, and we still did not prioritize that community. So while I was alongside y'all and I worked with you, and I am so grateful for the work that you did do because it could have been way worse, that's still a disappointing fact for me that we could have predicted it and we didn't know. And so we collect this data and I just hope we use it better moving forward.
Morgan,
Hi.
Morgan, thank you. I think that's a great point. Does anyone else have any questions?
Hi, this is Elizabeth. Can you hear me?
Yes.
Okay, great. In listening to the comments in response to Morgan's questions, I thank everybody for, learning on their feet, pivoting work. Obviously, this is something that we've never experienced before, and so you can plan, and then there's actuality. A couple things that resonated with me that I like to hold up are, there was a lot of, we hope that the next time we will be able to, and there was another piece that, but that's one that I really want to hinge on is that, the other one is around, we plan to do an assessment. And I think when we're looking at our data, we're looking at, at least locally, we're seeing some of a reprieve, and at least locally, the first wave is over. But if nationally, what we're seeing is any indication of what we're going to be seeing coming down the line fairly soon here, I think now is the time to assess. And now is the time to make commitments. And some of those things that come up for me, being a part of some of those conversations around how can we pivot and do pop-up testing and do those types of things, where should we do them? Having those conversations now with community. Like Morgan said, we know the trends. We know where the health inequities are in our community. And we know where we're probably going to see hardest hit areas again. So if we can make some commitments and act on them now, having conversations with partners to say, if we're seeing this again, can we make sure that, your church can be a testing site, your pantry can be a testing site, wherever, right? Setting up those opportunities now so that when we see a peak again or a spike again, we can act. And we don't have to have meetings in real time to try and figure out where we're going to be doing those things. And I think that this is also an opportunity, and I'm really happy to hear, Charles and Jimena and others saying that those community partners and actually who are community members, engaging them as a part of the process and as equal stakeholders in decision making, that we're doing that now, right? And as we build into surge planning, that those are part of the structure, because I think that's really important. That it's not a kind of a thing of we're doing this on the side, but let's hope we can incorporate it. That it actually is a part of it, and not an exception.
I appreciate those comments, Elizabeth. And just so you know, as far as the assessment, that's something we're talking about doing now. So it's not like we're putting it off for months. We're getting ready to start it like in the next like week or so. So it is something we're going to do very soon. And the other thing too is that we're working, and this is something that perhaps we can talk a little bit more about. We didn't get into the details, but we are working on kind of testing strategy because the state has recommendations based on different priority populations who we know might be more vulnerable. They have kind of a recommendation of cadence of testing. It's a little bit something, Dr. Mark has referred to it a little bit about, you know, people who are working outside the home should be tested every couple of weeks. So we're also working on kind of putting together this testing strategy with the understanding that we may have to not only have kind of a strategy for that ongoing regular testing, but also particular testing in response to outbreaks or clusters that we may see and how we will do that. So we can share more of that at a future Board of Health meeting too.
Great, thank you. I would really appreciate that.
I had kind of a side question, just so I'm understanding what's going on within the county. I think it was Charles, you referred to the Communities of Color work group that sounds like Elise convened. Could you tell me more what that is? And then is that part of public health's driving forward, or is public health informing this work group? I'm just not clear. I'm always confused by the different layers at the county and who's kind of saying or deciding what.
Right, Neil. Thank you. That's a good question. So the Communities of Color Task Force is what I should have said. I may have said work group, but I should have said task force. And that was created and convened by Elise, who's our racial equity officer, to really address the specific needs of communities of color that were really hardest hit by this pandemic. So we wanted to convene a group of people who were still activated and part of the response in their particular sector. And then there was also, and Elise has been very upfront and candid about this, convening this group that would be made up of professionals really of color and some community members to find out what resources, what the needs were in each of the specific areas that I mentioned, folks who were represented or are represented on the task force, and to see if there could be some resource sharing so that to reduce duplication and to ensure that all of the areas in which that are really represented or that have large representations of people of color, that we could address those needs. And so those community distributions were a part of that, spearheaded by county administration and also the sheriff's department. And so it was this group that was meeting weekly, and essentially, and how the meetings went were everyone would give an update and talk about their particular area and what they were doing. Our role really was as a public health response. How are we responding in terms of testing? What are the numbers looking like, particularly in the eastern part of the county? And what response efforts can each of the folks at the table contribute to respond to those, in this case, increasing numbers? And so that was the group. And as we move forward, as we're shifting and pivoting, as Elizabeth said, we're looking to figure out, okay, how can we respond in a more practical way via the use of policy and things of that nature. And so this is, although this group was convened, Neil, during COVID-19, the expectation is that it will continue to move forward and in a policy making and response, and to address many other responses or many other issues that are particularly negatively impacting communities of color in our county.
Gotcha. And Charles, that's really helpful. Thank you. And then a related question, and maybe this is for Jimena, is so it's really clear to me that if we had more capacity as public health, we could do more testing, right? Dr. Marquez observed that. And so as we navigate funding for the department to do better and more, right? And proactively. I'm just trying to figure out, so is the work group a place where that advocacy happens, or is that conversations with Greg Dill, or sort of, you know, I'm trying to narrow this into how can we also make sure we're resourcing public health so that we can do better the next time around, and the next time around might be in a few months, right? And maybe that's a place where board members can be helpful. And I'm just kind of riffing here, Jimena, but just thinking out loud on how can we make sure the solution, we have the capacity for the solution that Morgan and Elizabeth so effectively described.
Yeah, that's a great question. And I think that, you know, part of what I think as a health department, we have to kind of figure out, like, what are the most important kind of areas for us to focus on based on the typical work that we do as a health department, and where do we need those resources? And so, I mean, one great thing is that Elise is on the governor's task force on COVID-19 disparities. And so that's also a great connection in terms of advocacy for Washtenaw County, for resources coming to our county. I think that for the health department, while we, you know, it may not necessarily be that the most effective use of resources is for us to do testing. I think we certainly can act as a convener. We can, you know, be driving those testing strategies by working in partnership with our health systems, with other, you know, labs that are coming on board doing testing, using the data to inform those testing strategies. Quite frankly, I would say the resources that we need particularly are related to case investigation and contact tracing. We do not have enough staff at this point for that, especially if we see another wave and increase in cases. As Dr. Marquez mentioned, we have kind of this sort of temporary plan as we work out a more long-term plan. But that really is, I think, where we're going to need additional resources, and it's going to be a key area for the health department as far as, you know, containing the spread of COVID-19 and really doing what we can to keep the progress that we've made in reducing cases, you know, still happening. We have, I mean, I think in the health department, we've talked a lot about the concerns, and I'm sure you're all seeing it. If you go out, you know, it almost seems like with the lifting of the stay home, stay safe order and restaurants opening up and bars opening up, people feel like, oh, okay, I'm good. I can go out and about and go back to kind of my normal way of life. And we've already seen in East Lansing this big outbreak associated with a bar where I think they have more than 25 cases from people who were at that bar. So I also think that the ongoing work that we do around prevention messaging, the communication, and as Charles mentioned, really ensuring that that communication is developed in partnership with our community leadership teams and trusted community messengers. I think that is where, you know, the resources, I would say that's probably a big priority for us as far as resources. Not to say that testing isn't important, but as far as the actual work that the health department does, I think it's less directly doing the testing and more in these other kind of community mitigation and control efforts.
Thanks.
So I want to follow up on something that Morgan had mentioned in one of the comments that we had during the public comment period. So there was the comment mentioned census track. If we could report by track, is that something on our dashboard? And I think that would be really helpful with like overlaying it with the opportunity index and looking at things from census track as an option there as well.
I think Laura and her team are actually testing it out to see if they are able to do that, and have had conversations with OCED about layering COVID data into the opportunity index.
Great. Could we get updates on that? Because that seems like an excellent use of the opportunity index. Because then we could really direct people to that. We should be directing people to that resource, but to put the COVID data in there could be really helpful.
Yeah, absolutely. And actually before COVID-19, I had actually planned to have Teresa Gelati come to a Board of Health meeting to present the new opportunity index and talk about it. So, so hopefully that will be ready soon, and we can have some time to talk about the opportunity index and the COVID-19 data that we're looking at. And I think as far as the census tract, that's something that we have gotten requests for, and it's Laura can probably, well, she's not on anymore, she could speak to it more directly, but it's a very time-intensive part of our data collection process because we don't necessarily get information by census tract. So there's several layers of doing that, and I think at the time we just during the response didn't really have capacity. And so that's definitely something that we've talked about and hope that we can get more to that census tract level as we continue to gather data.
I also want to echo what Morgan said about, I don't want my suggestions or any of those kinds of comments to be looked at as a critique of the staff or the health department, because the staff has done a tremendous job. Jimena, you've done a tremendous job, especially compared to other health departments across the state and the country. We can always do better, and I mean, that's just what the conversation is about. But I mean, it's just been incredible work that the health department has done.
Thanks, Justin.
Does anyone else have any questions or comments? Dick, you need to unmute yourself.
Yes. First of all, I want to applaud your efforts. Everything is great. I was surprised to hear about the resources being provided to the contacts, and I'm wondering, is that typical of other health departments in Michigan? Is that just the standard operating procedure, or is Washtenaw going above and beyond? Thanks.
Jimena, I think.
Sorry, I know. I was muted. Sorry about that. I think we have a pretty, I mean, I won't say there aren't other health departments that provide resources the way we do, but I think we have a pretty unique case investigation contact tracing model that really borders almost on a case management model. And our staff, I also want to say we've also used not only reassigned staff during this time to help support that model, but we've also used a lot of volunteers through our Medical Reserve Corps. And so, so because of that, we've been also able to support these kind of additional resources. So I think it is, I wouldn't say we're not the only health department doing it, but we certainly are pretty comprehensive in our approach.
Well, I don't think the general public is aware of those efforts, and I think whenever you have an opportunity, it would be good to point that out too.
Anyone else?
Yes, I do want to echo the tremendous work that all of you have done during this pandemic. I can't imagine that. Oh man, wow. But I see you smiling and still working. And so I'm very grateful to be part of this group and just really applaud your efforts. In alignment with the contact tracing, it sounds like this is where the efforts are moving towards, and you're trying to increase capacity. Now, is this something that, I think I may be getting more into the weeds, but that students, undergrad students, like particularly in School of Nursing or other schools can, partake in and have an opportunity to do as part of the rotations?
I mean, I think that's certainly something to explore. For the summer, one of the reasons that we were able to sort of use students and it supported the model that we have is that they're able to work pretty much full time during the summer. And also they're getting some, because many of them had internships that fell through because of COVID-19, the schools are providing some funding for their positions. So I think the challenge with students during the rest of the academic year is their time, because we really do need more hours during the week, especially because we have those metrics that we are measured against, right? In terms of the contacts and the timeliness of making those contacts. So I think that's the only challenge, is in terms of what the availability would be, and how that would support our model. But we certainly are open to, and we'll continue to look to how we can support our efforts with students, nursing students, medical students, public health students.
Great. Maybe that's something that we could talk more about offline. Thanks.
Anyone else? All right, I'd just like to close by saying something. A couple of board members said something along the lines of, I don't mean to sound critical. I want to tell you all, I encourage you to be critical. I think we can support staff, and at the same time, the role of this board is advisory. The role of this board is to be a little bit on the outside and say, hey, could we do better here? And I don't talk about it much, but my pre-law career was as a sports writer, and no athlete gets better by focusing on the things they do well. No one improves by focusing on the things we do well. And I think that a lot of the frustration we're feeling in America right now comes from everybody recognizing problems and even sometimes talking about problems, but nothing changing. And so I think it's really important to close by talking about what both Morgan and Justin talked about, that we know now where we wished we had done better. And we really feel like there's likely to be a second wave in the fall. We have to come out of this and make sure that we do better in the fall, a lot better, particularly in these areas where we knew there was an underserved or at-risk population, and we wished we had done better this time. And that's not meant to be hard on anyone. It's meant to say, we have a great health department. We've done really well in a lot of areas, but we have to do better in this area. And we have to do better the next time we're challenged. All right.
I appreciate that. Jim, I'm sorry to interrupt, but Felicia is on, and she has another meeting that she has to get to. So she's wondering if she could do her report before we move into the budget.
I approve of that if everyone else does. All right.
Okay, thank you.
Thanks so much, Jimena and Jim. Hi, everybody. The biggest thing that, well, there are two things. One, Charles was talking about the group that Elise has brought together with Aldous and Morgan's on that. And the other thing that we're also keeping in mind with that group and with just the creation of it is now having a standing group of leaders in the community, and those of us who are there getting together regularly to be able to be much more strategic rather than reactive, which is in terms of all sorts of issues. And so, my hope is that, as that group continues to meet, we're literally just moving into that phase. And, as we continue to be able to meet, to be able to think much more strategically about how we respond to any number of issues in our communities of color here in the county. And so I think that that group's existence and being able to coordinate and collaborate with other existing groups is really timely in terms of being able to do things better, which we need to do. So I just wanted to make that comment. In terms of the BOC, we are generally, there has been a lot of praise for Jimena and public health for responding, and all the hours and hours and hours that have been spent trying to keep our county as healthy as we can. And so the board has been, I think, very grateful and proud of the work that we have done, and knowing that we can always improve and do better, and seeking to kind of do that in the future. The other thing that we are going to be doing, because we're now in our summer schedule, so we only have one board meeting a month. So that will be next week. And one of the things that we will be voting on during that meeting is a resolution declaring racism as a public health crisis. And I know that we talked about it a couple of years ago. I brought it to the board from a GARE meeting. And, it feels like there's a lot more momentum behind it now, which is great. And so that resolution acknowledges the resolution that we will be taking up as a Board of Health. And so, and also, Neil, you asked a question about budgeting. One of the things that when I was writing the resolution, tried to do more so than other resolutions that we've seen throughout Michigan, but also the country, which make a value statement. I tried to have several action items in as part of the Washtenaw County's resolution. And right now I've listed, I think 6 or 7 action items. And the first action item is increasing the budget for the public health department. And so I think that, and the language that I used in this resolution is that that the board has a responsibility to enact policy that may include, but is not limited to, the following action items. And the first one is increasing the budget for public health. And so that is something right now that Elise is taking a look at, a couple of other commissioners are taking a look at before I forward it to our entire board. And also share with Jimena for some suggestions as well. But know that the Board of Commissioners is going to be taking that up, but not only the value statement, but action items as well. Well, hopefully pushing my colleagues to accept, and to do something, not just to make a statement.
Anyone with any questions?
Felicia, this is Neil. I know you're on the phone, so you couldn't see me nodding, but I appreciate the information on all points. Very much appreciated. Thank you.
Yeah, no problem.
All right, Felicia, it appears we have no further questions, so we will move on to our budget presentation.
Thank you so much, everybody.
Have a nice weekend.
Thanks, Felicia. Okay, so Jennifer's getting set up. I just want to again thank Jennifer for all her work in putting this next fiscal year budget together. As you can imagine, it was quite challenging given kind of our current situation, and she certainly has done an amazing job given that she wasn't able to kind of use her usual process. And there are still a lot of kind of unknowns out there, but thank you, Jennifer, for all the work you've done in putting this budget together. And I think she's ready to go through it with you, all of you.
Are you able to see the screen okay?
Yeah.
So we're going to be going through 3 things ideally today. One is a brief look back at how we closed the 18-19 fiscal year, a budget update of what's happening for 19-20, and then the proposed budget for 2021. I will be clear in saying what is proposed for 2021 when you see this again in July will be completely different. As I finish this budget, literally additional information was coming forward, and even into last night at 9:11 p.m. additional information was coming forward. So I did try my best in order to create a budget that you could review, and you did get it in your email, but do know that what is presented today for 2021 will be uniquely different, with a higher budget amount, and I don't know what amount of fund balance to use. So we're just going to start real briefly with the 18-19 look back, and this is to highlight that we did end up using $103,000 of our fund balance. That left about $2.7 million in our fund balance as of 10/1/2019. One of the directives I've been given was to highlight those items that are kind of just of significance. And there are a few items to note, and that was the essential public health service increase that we ended up receiving of almost 132,000. We did receive a hepatitis A award of 120,000. And then we had 3 new grants come through in our final amendment, an EPI capacity grant, which allowed us to get iPads for our environmental health staff. And it also allowed us to cover our web service that we have for data analytics around health data. Into the 1920 review, if you remember, the original budget was almost 15.2 million. The mid-year budget came in near 15.8 million. And right now I have no idea of where we are going to end in our financials. There has been so much change that has happened, including one of the most recent items was Senate Bill 690, which actually will appropriate some level of CARES funding to cover COVID mitigation work for the health department for the month of April and May, salaries and fringes, as well as some costs associated with public safety around COVID. That is work that we are actively processing, correcting entries on, because all of those payroll charges had been being moved to a proposed FEMA project, and now we are directing that into CARES. So there is about 4.5 payrolls that need to be managed and update. And that is work that has been happening over the last 5 days since we received notification of that Senate Bill 690 Thursday last week. As a reminder, and you did see this as part of the mid-year budget, it's really just to highlight what the landscape looks like when it is the original budget that is presented, but then everything that happens throughout the year that makes the budget change. So these next 2 slides were presented to you during the mid-year budget adjustment discussion that happened in January. The one change that I will highlight is toward the bottom, our family planning appropriation, as opposed to $317,841 that came in at $317,000. So again, this is not new information. This slide and this slide is identical to what you did see in January. What I do want to highlight though is what has happened since we talked in January. We have had new awards for COVID response, 50,000 that is to be used by the end of this fiscal year, and then 125,000 and 222,000 that we're able to carry forward. It's effectively from March of 2020 through March of 2021. So right now we are kind of holding tight on you having access to that $347,000 while we're seeing how the CARES money that is from Senate Bill 690 pans out. But we have also received, besides that COVID money, we've received perinatal collaborative funding, some slight increases in emergency preparedness, sexual health services, and a new grant for vector-borne surveillance, as well as some community stabilization money. We saw a huge spike in our essential local public health service money that came in our 3rd amendment just in the last 30 days from the state for an increase of $278,534. Also a Hep A response award that we were not expecting at all. And then the state did give us about $83,511 to help with our FEMA match. That is an application we are operating under the county structure for our FEMA application to help defray costs associated with mitigating the spread of COVID. We also had 2 grants from the Ann Arbor Area Community Foundation for $9,000 each to help with supplies and some support to our 9798 and then other areas. And then just kind of moving into the FY20 and overall unknowns and kind of what I'm looking at. You know, I think I've mentioned before, it's hard to kind of glance into that crystal ball and figure out how everything is going to land because things move and change so quickly. So some of the items is really in regards to how do we operationalize COVID as we are considering our other work that we were doing pre-COVID. Also catching up with the county closure because the county was formally closed for 3 months. And so much of our work that we didn't deem necessarily as essential that Ruth had alluded to during her session, we're now trying to catch up on much of that work as it relates to, you know, permits for wells or septic tanks, or going back and connecting with our families through our maternal infant health program or our children's special health program. There's quite a backlog of work that we're trying to get to. We're really trying to focus on meeting as much community demand and coordinating the community impact as possible. And then triaging a series of revenue sources that I feel like I just get a beat on them and then something changes. If you are not aware, the state of Michigan received nearly $3.9 billion in CARES funding. There were 5 communities that have a population of over 500,000 that were able to get that CARES funding directly. Because our population is not that high, our portion of CARES funding, or what I call our portion of CARES funding, went directly to the state. And it is only with the Senate Bill 690 that there has been some type of financial impact to the health department as it relates to that federal funding. And right now it is only for 2 months of staff costs. And we know that we have had costs associated with this pandemic since the beginning of March to current, and we will for the foreseeable future. So it's kind of hard to process when there has been some really great things happening in those communities that did get access to CARES funding directly, that we're trying to manage with just a limited shoestring budget because this pandemic was not budgeted as part of our mid-year budget adjustment. Specific to that Senate Bill 690 and why we're in such a hurry to finish triaging all of those payroll expenses is that the state approved the bill, and then now we only have until July 17th in order to turn the invoice around. So it's a very quick turnaround time. And then also another unknown financial impact, it relates to our FEMA application that we have in place for our isolation and quarantine housing. That is potential for a 75% amount to come in from FEMA, but then the 25% match we would need to cover, and we are hopeful for some state funding in order to cover that. And then some unknown financial impact is the personnel expenditures during the county closure. When the county effectively closed on March 15th, the contracts for union were implemented under the Act of God status. And so if anybody was actively working, we as the employer were required to pay overtime for anyone who was in a union. Any of our non-union staff, we could work as many hours and we were receiving our regular rate of pay, but anyone who was in the union, they were receiving it sometimes 1.5 compensation and sometimes an additional 1. And that's in addition to their base compensation because the county did pay everybody during closure. Another one of our unknown financial impact is we have our isolation and quarantine housing, and right now we are paying for 110 rooms and currently have 1 client there. And a lot of that is based on the venues that we're working with. As soon as we tell them what our purpose is of utilizing that facility, they are not interested in being able or not able to, we'll say, market their facility for other people who are just looking for accommodation. So we have been effectively since almost the 3rd week of March paying for isolation and quarantine housing to the tune of sometimes $5,500 per night. And we had a max of between 13 and 18 people utilize the facility in like one event. There's been one person or maybe up to 5 people periodically, but until yesterday, the last time we had used our isolation and quarantine facility had been the Saturday before Memorial Day. So I went through FY 18-19 and FY 19-20 very quickly before I move on to the actual budget. Is there any questions? And I can't see all the list of people, but if you have questions, please feel free to ask them or just email me, whichever you feel more comfortable with.
Does not look like anyone's raising their hand, either electronically or online.
Okay, thank you, because I can literally only see like 5 people and I'm one of them. So I appreciate that. All right, so Jimena is absolutely right that preparing the FY 21 budget is like no other budget that I have ever had to prepare. It was just different, and it was very late. Typically, I would have started preparing the budget in mid-March, but unfortunately, I was reassigned effectively at that time for our incident command and spent a lot of time doing what I could to help with the COVID response. So again, thinking about what is happening for our FY 21, we really needed to think about considerations for operationalizing what our COVID response is going to be. And thinking about it, yes, in a long-term, but not in a permanent long-term model. So thinking about it as a 18-month response, not a 5-year response. The ongoing community demand and community impact was definitely something front and center, but also an economic, what is the economic impact? Are we going to see a decline in construction? Are we going to see an increase in people who are eligible for Medicaid services or just are eligible for services in general and don't have insurance, and we need to figure out how to support that? Also, we have this underlying MAG salary survey that we have continued to talk about. Our county HR continues to work through that, and I do not have an implementation date still. On the financial side, I'm being told at the county level that there's no money to implement the MAG salary survey, but on the county HR side, I'm being told that we have to take some action because we have the data, and they're still actively working on it. Our grants that are ending, as that I know of right now, is our Building Healthy Places and Wise Choices projects. Building Healthy Places is kind of a hard one to see end because it has a significant community impact, including funding for food gatherers. Safe Sleep is sad to see that end. We've had that grant for several years. Vector Surveillance, it seems to be this one that comes in our final amendment to the state, but I have no information that it will continue. And especially with the budgetary shortfalls that are happening at the state right now, it's hard to kind of predict what revenues to expect or not expect. This COVID-19 for $50,000, at literally last night at 9:11 p.m., I received an email from the state that said, hey, here's your appropriations for FY 21, and that $50,000 is in there again. So I'm waiting to hear back. Sent a massive emails this morning to the state clarifying some of those appropriations, because last night was literally the first time that I had a glance at what they were proposing as our appropriations, even though I had built this budget, 2 weeks ago. Another grant that is ending is our Medical Reserve Corps for $7,500, and then a large grant that will end in the middle of our fiscal year is the Community Mental Health Anti-Stigma Grant, where it's a partnership where we're doing some of the communication and education for the community mental health team. Jimena has some confidence that that grant may continue, but we have not been able to enter into those conversations as of yet. A few grants that we just do not know the status of, if they will be funded in part, in full, or not at all, and that is our Perinatal Collaborative Grant. That is a large partnership with U of M. Medical Marijuana, which is typically an annual grant that comes in toward February, and then we have about 8 months to do the work. And then also our Prescription for Health project, which is funded through Trinity Health Systems. It's an annual grant that we just don't know in full, in part, and how that might impact our community, because that definitely helps us with supporting some of the chronic disease management for our community members. The proposed FY21 budget, this is the revenue side. The budget is very close to the mid-year budget adjustment. I'm literally within, I think, $13,000 of what was approved as part of mid-year. And a lot of that is really because we ended up pausing our fiscal year and not implementing some of the pieces. Like we had budgeted to implement family planning on, and because of COVID, not implemented until October of 2020. In the licenses and permits, that is mostly revenue that comes in from the environmental health side. I've flatlined that revenue. I am not anticipating any type of increase right now because the information that I had in front of me was that we can anticipate a small economic recession until about 2022. I'll be happy if that doesn't come to fruition, but based on the information I had in front of me 2 weeks ago, that was the data set that I was looking at with county administration. But overall, it's a almost again, a $15.8 million budget from the revenue side. And similarly from the expenditure side, it's matching with the significant amount of our expenses around staff time. And I just want to highlight right now on the revenue, and I'm sorry I bounced back and forth, but this current budget does propose a use of fund balance of $400 and almost $23,000, but I fully anticipate that that will go, well, based on some conversations, it will go down because of information we have from the state about additional funding for contact tracing and case investigation. Or it could remain flat at that $423,000 because we're just going to commit to additional support for contact tracing, investigation, communication, and other things that we have to do for COVID mitigation. So our next steps, we're here today with the proposed budget. Again, the final draft budget that will come on July 24th will be different. I will send that out likely a week before, and highlight what new has happened over the last several weeks. And then we will submit the budget with the cover memo and resolution to our county administration in August. And our plan is to take the budget on the September 9th and the September 23rd commissioner meetings. So I know I went through that really quickly. I also tried though by sending this to you in your email earlier this week, be able to give you an opportunity to look at the information in advance and, quantify or think about any questions that you may have. I'm pretty much working a lot right now. So if you ever need my cell phone and to talk through something with the budget, I'm open to that. It's really just figuring out how we can think about supporting our community as best as possible without jeopardizing our financial integrity. That's kind of my lens.
Hi, can everyone hear me? I just have a couple quick questions for Jennifer.
Yep, go ahead, Leanne.
Yeah, the ending grants, have we made an effort to reach out to those and see if we could get a COVID extension? And the second question is, the word on the street is it'll be about 2 years before a vaccine will be made. And I was wondering, you talked about the projected budget being for 18 months, and I was wondering why not 24?
That's a good question. So first and foremost, our budget only runs on a fiscal year. So it's okay. So I'm not going to, I have a lens into an 18-month, but I'm only going to present you with what the 12 months is going to look like. And then it's to the grants ending. We were given very clear information from several of these that were going to be done, and we would have exhausted the funding anyway. So our building places, Wise Choices, Safe Sleep, Vector, the money's all been exhausted and they're not being renewed. That we have confidence building healthy places, Safe Sleep and NACHO are not being renewed. peer surveillance and the community mental health anti-stigma, they could be, but we haven't entered into any conversations at that time, at this time.
Okay, all right. So I want to make sure we at least ask.
Yeah, do have grants that we've asked for no cost extensions on. There is a NACHO grant for opioid mentorship that there has been a no cost extension. Has been working with the state on an SOS grant, and that one has a no cost extension. I still don't have the contract with the state yet for that one, but we did get an extension.
Okay, all right. Thank you.
Were there other questions?
It looks like Kathy has her hand up. I think you'll be able to unmute yourself.
Yeah, Jennifer, can you hear me?
Yes, I can, absolutely.
I can't see you, but you're beautiful. This is Kathy. You know, my concern has been consistent over the years. It has to do with a 4-letter word, fees, F-E-E-S, you know? Yep. $697,654 that I read. It's stuff you sent to us, and I thank you for sending all that out to us, etc. And you know, I don't want to take the time now. There's so many, you know, pressing issues. I just want to ask you, or I want to, when get in contact with you and the rest of the board, I want to investigate the fees. I mean, I want to know that if we still charge for HIV tests, for example, do we still charge for, you know, the well baby clinics, and the fee schedule that went into effect last year, which I voted against, it had a huge increase in percentage of just walk-in fee. And so I want to talk with you about that when other people aren't listening, okay? I mean, I need more information about that.
Okay.
Okay? Thank you. Well, go ahead.
I was just gonna say, I would like to answer though the question. We don't have a well baby clinic. We offer immunizations for infants. And if a client is uninsured, they would be eligible for our significantly discounted and sometimes free services that we offer based on the sliding fee scale, or federally qualified vaccines that we have. So we're very conscious in our clinic that we will always charge a client for anything, and we're not turning anyone away from the ability to pay. We have a very good model in place that was highlighted during the mid-year budget adjustment that we presented to the board of commissioners as far as how we work on or like operationalizing our clinic if with a client who has an inability to pay, because we do receive some state grant dollars. We just don't receive enough state grant dollars in order to offer free. Full on, everyone is free. And if somebody has the ability for us to be able to recruit, that means that we're able to offer services.
Okay, thank you very much. I still, you know, I am telling myself that I must get my head around all these issues in relation to fees and talk with you later. But I'm sorry, my phone has been going in and out on audio, so it's been real hard for me to hear. So thank you, and I'm not going to say anything else except vote yes when I'm supposed to. Okay. Thank you. Bye-bye.
And I would just follow up, Kathy, to say Jennifer and I will be happy to follow up with you to have that conversation. And then just a couple other things I wanted to share. I thank Jennifer for her work preparing the budget, but also want you to know that she's been working really hard with county administration to do all the documentation necessary for FEMA reimbursement. It's been a huge amount of work for her and her team. So just know that she's been doing this work as well. And then I wanted to just go back to the isolation and quarantine housing that Jennifer mentioned. that is a responsibility of the health department. And so we engaged in this contract with a local hotel to meet that responsibility. But I do want to share that we're looking at an alternative solution in collaboration with St. Joe's as a possible different solution that would be more cost effective and really kind of meet the need that we have but still giving us increased capacity should we see increased demand for that isolation and quarantine housing. So just wanted to share that.
All right. This is not an action item at this time, correct, Mena?
That is correct. This is a time for you to review the information, ask questions, get any additional information you might need. And then in that timeline that Jennifer shared, July would be the final presentation of the budget and your vote to recommend the budget for approval to the Board of Commissioners.
Excellent. All right, we'll move on to old business then, Title 10 Family Planning Services. We are also a little bit behind our schedule. I'd just like to point that out. I'd like to make sure we have a lot of time for new business.
Absolutely. And I'll be really quick. I just wanted, and Jennifer mentioned, just so everyone is aware, our start date for Title 10 is pushed back to October 1st. We are still in the preparation and planning work phase of that, getting ready for the launch in October 1st, hiring nursing positions and getting all of the policies, training in place. And certainly we want to be we want to offer the services still, and we know that especially during COVID-19, there's been some reports of limited access to family planning services, reproductive health services. And so we're anxious to make that available. The facility improvements that we had planned in relation to family planning are kind of on hold at the moment, but we do look forward to starting that program October 1st.
Excellent. Any questions? Seeing no hands raised, either online or in video, we'll move on to new business. And our first item on new business is our resolution declaring racism a public health crisis.
Yeah, so I'll just give a little bit of background. I don't want to take too much time because I want there to be plenty of time for all of you to discuss the draft resolution. We talked about this with the executive committee and they felt it would be best to make this a timely decision and effort to present a draft. So this is the draft that we worked on. And we looked at various other similar resolutions and statements that have been developed by other health departments and boards of commission around Michigan, as well as in other states. We also tried to include some local data to make it more specific to Washtenaw County. And most importantly, I want to thank Marta Larson and Alex Thomas for their comments. I think that, as Marta said, we really tried to think about how to make this not just a resolution sort of declare with this declaration, but really including some actionable items and some work that we as the health department commit or recommit to. I do want to remind board members that we have been working on health equity issues for many years now. We have the Community Voices team. We now have the Healthcare for All Steering Committee. And we have, I think, more than a year ago, probably close to a couple of years ago, we developed our own equity statement for the health department and principles. And in those principles, we name racism and other isms as a barrier to health equity and social justice. So this is not, this is not new necessarily for the health department. I think we have long recognized racism as a public health issue and have really centered our work in working in partnership with community stakeholders and community members, and really looking at those social determinants of health and the policies and structures that impact those health inequities. But I think that we obviously are at a time where we need to really not only recommit, but evaluate what different work we can do, as Jim mentioned so well, to really make some change in our county. And so I just want to kind of give that background. We also look very much to the American Public Health Association in terms of guiding some of the language in this resolution, because they have also very much been on the forefront of naming racism as a public health issue. And one thing I just want to point out, and before we get into reviewing the resolution, when we originally drafted the resolution, it was naming racism as a public health issue. We changed it to naming racism as a public health crisis. And we had a little bit of an internal debate about that, because on the one hand, crisis certainly elevates the issue, brings, signifies its importance, but also sometimes a crisis is more of a short-term situation, and this is not a short-term situation. And so I'm interested in your thoughts on that, as well as in general the content of the resolution. We know it's rather long, but we really thought, let's put everything in that we'd like to have in there. And as you heard Felicia say, the Board of Commissioners also is going to be using this resolution in their work as well when they talk about this on July 1st. So with that, I will be quiet and look forward to your feedback and comments on the resolution.
I think it's a great resolution, very strong. I appreciate how strong of a stance each of the statements are, particularly in naming racism and then pointing to all the evidence from other outside institutions. I like the use of crisis as opposed to issue. With using crisis, I think that will signify that we will be taking ongoing action. It's not a problem that's going to go away anytime soon, but calling it a crisis, because it is a crisis, but also indicates the health department's ongoing commitment to taking action.
And I would just like to echo those remarks. As I read through it, I was constantly asking myself, because in the past, as far as my background with resolutions, there was a time when we got resolutions from our governor around HIV National Test Day, and it was a nice paper with pretty words on it, but the bottom issues never really changed. So I'm hopeful that with our resolution, we'll actually be able to get some change to happen. I'm wondering what's the, oh shoot. Oh, I got an important call I just got to take. So I'll have to step out for just a second.
We've all been there.
I really like the resolution also. And I love the way you're framing it around the crisis as a long term. I think that's important because racism is systemic and it's not going to just be a quick fix. I acknowledged it, now it's over. The only thing that, and I don't even know how to word this, and I think I was looking for it in there, so I did see it. I don't know if it's explicit, but it's one thing to work on policy procedures. It's another thing to do like the internal heart work that informs the policy and procedure. Like you can be well-intentioned and still create a racist policy and procedure because you really don't understand what racism is or how you play it out. So how do we get at that in this resolution so that it's clear that we're asking folks to do both the system work and the individual interpersonal work that informs the system?
I'm glad you raised that, because that was actually part of our conversation also as we were internally reviewing this draft, because we wanted it to be not only externally focused, but also internally focused. And so I think, the third to last, be it further resolved, tries to get at that, but I hear what you're saying. And I think part of our conversation was how do we reflect that internal work and ongoing kind of learning and assessing that you're right, is outside of the policy and the practice and the procedures and, the budget. So I'm open to suggestions for that. I'm not sure I have an answer either. We struggled with it.
I mean, what comes close to it is the GARE. So I like that you mentioned GARE training. And because I don't know, was or am, because I don't know where the county is with GARE, but because I facilitated those trainings, I do know that some of that is in there, but there's not a huge emphasis on, so I don't know either, but I do know it needs to be in there somehow, or else nothing changes.
Yeah, I
Agreed.
agree. Absolutely. And then looking at what are those measurable outcomes that could measure not just the external change, but what is the internal change? Because we all know that we could take an education course or training, but it really doesn't change our behavior and thought processes. And so I think what this has helped me to do is kind of now take a look at those strategic initiatives, to see, are we measuring the outcomes and that we want to get at that internal and external change that we want to see as well. And so I think it would be helpful to explicitly state maybe some of those outcomes and changes that we would want to see, especially if as our public health commentators pointed out, that we want to be able to, walk the walk. Absolutely, once this is declared, and to be responsible to making those changes.
So is maybe a potential suggestion could be to include a statement about a commitment to evaluating our progress and efforts.
And Morgan, did you mean as much as the internal as the externals? And Justin, just to clarify, when you're saying evaluating, you mean also sort of our work to internally evolve and reform, right?
Yes.
The health department, in addition to the external work that the health department does. So with that in mind, I really love that idea.
Yeah,
that's a great suggestion.
This is Elizabeth. I would really love to see more emphasis on what we're committing to in the future, right? As opposed to what we've done in the past. But because it's clear what we've done in the past isn't enough and isn't really doing what it needs to be doing. So I would really love to see more of that fleshed out here.
Maybe another way to get, this is not internal, but I think I don't know if it explicitly, I'm reading it and I'm looking for it. So I think I'm finding it, but I don't know if it's there without me looking for it. Is also the piece around making sure there's leadership of color, like intentional. And I think like when you say we'll review policies, practices, procedures, internal, that kind of alludes to the fact that we would have an equity lens in our hiring process, but it's not explicit to say we are going to make sure that we'll have a diversity of leadership that can attend to these things.
So I'm just taking some notes. Any other feedback?
Hey, question. So I'm excited for public health to declare racism as a public health crisis. Felicia mentioned county commissioners are also declaring. So Is that a completely independent effort or Jimena, are you informing that, since obviously you're the representative of the public health department? I just want to make sure you get to inform what they're saying so that our statements at least resonate with each other. They don't have to be the same thing, obviously.
Yeah, Felicia and I have actually had conversations and have been talking about, the content of the resolution so that they kind of complement each other or are connected in some way. So yes, we've been coordinating those efforts.
Thanks.
I can add, if Jim, if it's okay, I can add a little bit more too.
Oh, is that Felicia?
It is.
Oh, hi, I thought you were gone.
So,
yes, please chime in.
I thought I was too. I know it's meant to be too. But I hung around.
Great.
So, yeah, so like Jimena said, she and I have been in contact several times about the resolutions, and I think that they really dovetail nicely together, and they will dovetail nicely because, while the one that we're working on right now for public health is about the public health department, the one for the county takes into account, and I've written in be it therefore resolved that the Board of Commissioners accepts and approves the Washtenaw County Board of Public Health's resolution from today, assuming that it gets passed. And also talks about some of the same, I don't know if you had these statistics in there. Oh yeah, so the life expectancy statistic is in there, things like that, but also is broader in terms of both the work that the county can do within and with, in collaboration with other departments in addition to public health. And I think is an opportunity for us again I'm seeing this as an opportunity for us to really push forward, working intentionally and strategically to be able to move the needle, since we're still trying to make movements, and we have done some, which has been great. But I feel like this is another opportunity for us at the county level to be able to push again.
That's great. Thanks, Felicia. Sorry, I didn't realize that you were still on. So thanks for